Our next speaker is Peter Mabbutt. Peter is the president of the British Society of Clinical Hypnosis and a fellow of the National Council of Psychotherapists. He is also head of academics for the LSCCH in the UK and LCCH Asia. He's been practicing and teaching hypnotherapy since the mid-1990s, having moved from a career as a researcher in psychopharmacology at Guy's Hospital in London. Working with all aspects of hypnotherapy, Peter has a particular interest in pain management, trauma, and the mind-body connection, as with psychoneuroimmunology. He also treats those presenting with relationship issues and has a focus on the often overlooked psychological challenges faced by men. Peter has developed, evolved, and written many courses in clinical hypnotherapy that have been delivered worldwide. He has written an MSc course in clinical hypnotherapy that was run by a leading British university, for which he was the program leader. He's been instrumental in setting up hypnotherapy, pain management clinic, and pain research programs at the University of Malay Hospital, Kuala Lumpur. Peter is also a consultant for the hypnotherapy unit at the Pantai Hospital in Kuala Lumpur. He regularly lectures to the international medical community on the use of hypnosis and is frequently invited to speak at conferences around the world. The title of his talk is Trapped at Home, Domestic Abuse. Thank you.
Thank you, Tom. Thank you very much. And hello, everyone. Nice to see you again today. And the subject of my talk today is, unfortunately, the subject matter cannot be taught in a very light way. It is quite a demanding subject. It's one that is kind of pushed underneath the carpet, so to speak, quite often, simply because I think people are a little bit nervous about talking about it. And we don't want to think about the subject of abuse in the family. And so what I'm going to do is I'm going to go give you a nice overview of what is, we think, happening in the world at the moment with regards to COVID, the rising levels of abuse that we're receiving or we're seeing. We'll have a little look at finding out a little bit about what some of the potential indicators are for this type of abuse, and some very careful putting in some careful boundaries and some advice about not being too enthusiastic in labeling people as being abused. But also we'll also look at the very end a little bit about the recommendations that are coming out with regard to how we can improve the amount of people stepping forward to being able to treat people suffering from this increase in abuse. Now, the one thing that I think we're all very aware of is that domestic abuse is a global pandemic. It's something that prior to the COVID pandemic, it's always been there, it's been out there. People have been suffering from this type of violence in the broadest term. And it is something that is unfortunately never going to go away. Statistics are showing that 1 in 3 women are victims of domestic abuse. The World Health Organization has put that statistic there for us. And rightly so, we're focusing on women, but also we do have to have that understanding of what's happening to men in these situations. Men are also kind of pushed to one side a little bit with regard to domestic abuse. And recent statistics are now kind of showing and kind of indicating that there are an equal number of men who are victims of domestic abuse too. More men are coming forward and disclosing that they have been the victim of some form of domestic violence in their life. Now, what I think we need to do at some point, not in this talk, is explore perhaps why men have been so reticent in coming forward. As I say, that's something for another time. But we do know when we're looking at the pandemic that all types of family violence have increased. And what we mean by family violence, obviously we're talking about the physical aspect of it. It is what most people think of as family violence. The name implies hitting somebody in that sort of way, but it also encompasses, the term encompasses other elements, the sexual element, the sexual abusive element. It also encompasses the psychological abuse, a very insidious way of hurting somebody that is just as damaging, as you probably are all aware, as sexual abuse and physical abuse as well. But there's also the element that people sometimes don't consider family violence, and that is the economic abuse, the restriction of money, of prohibiting somebody from exercising their ability to buy things and to buy things that might be of pleasure for themselves. And another area, obviously, this will incorporate child abuse, but we don't often recognize that abuse can also be perpetrated by children. And within this experience of increase in all types of violence during the pandemic, we are aware that abuse by children is there as well. Now, the levels that we've been seeing globally, these have been estimated based on several studies that have been looking at the number of people calling domestic violence services. And it kind of, you look at the percentages, or the percentage increase that's coming from that, it does show some fairly disturbing numbers. In Europe, we've been seeing a 31% increase in calls to domestic violence services. So that is extrapolated to say, well, there's probably a 31% increase in domestic violence going on anyway. In Southeast Asia, we're seeing a 33% increase. In Australia and New Zealand, 30% increase, and a similar one in the USA and Canada. And what disturbingly that's showing is that this percentage of around about 30% is a global phenomena. And if you look in Africa and other regions of the world, you see a very similar amount of increase happening there. Now, interestingly, I think for us, globally, we are seeing a decrease in non-domestic crime and non-domestic violence during the pandemic. And it might be a case of, oh, right, well, it's rather obvious people are not going outside and they're not able to be outside during lockdown, etc. So, of course, crime is coming down. But what this implies is that it isn't necessarily coming down, it's being transferred into the home, especially the violence element of this. And we also need to remember, very much remember, that the increase is irrespective of gender identity, of sexual orientation, of age, as I said before, with children, and also religion and many other factors. It's a global across-the-board trend that people are experiencing and that we as therapists will be seeing within our own therapy rooms. So why perhaps is domestic violence increasing? And there are many different factors that are being hinted at as being part of this. The first one is the potential for isolation. With isolation, where you are taken away from your social structure, you're taken out of your social interactions with the world outside, that tends to focus people on loneliness, but also frustration, increased tension, because they're not unable to meet people, their external needs of social interaction and physical social interaction, seeing somebody face to face, not necessarily on Zoom, that is creating the tensions, which, if you look at certain people who have a predisposition towards violence, their level of tolerance is very quickly reached, and it goes over, and that's bang when they start to come out with hitting people or being emotionally abusive or anything else. And as part of this, and separate to this, I would also say, is we've got increased alcohol consumption. Again, this magic 30% comes in. There's been a 36% increase in alcohol sales. And again, this is a global increase that's being that's basically being hinted at here, or it's being stated at here. Now, we need to remember what alcohol is. Yes, it's a nice drink, a nice vodka or whatever your drink is that you like. It's nice, it has a flavor, but it has alcohol in it. Alcohol is a disinhibitor. That's the one thing. That's why when you go into a pub or a bar or a social event where alcohol's on sale, early on everyone's buzzing because they've had a couple of drinks. Disinhibition occurs. However, for those with a violent tendency, or those who are adversely affected by alcohol consumption that produces a violent outbursts, that is when that then triggers the domestic abuse at home, to partners, to children, or perhaps teenagers to their parents or siblings. So you've got those two factors coming into play. Likewise, you've got a whole arena of other substances being abused. This went up as well, around about the 30% rate. But what we're looking at here is typically the types of drugs of abuse that will cause violence are the stimulants, those that start to stimulate your brain, potential rise in adrenaline and other brain areas involved in stimulation, might go to the amygdala, which causes aggression. But what we're seeing here is that it is triggering these violent outbursts against family members. And with the hallucinogens, if you're having a bad trip, then you might just lash out anyway. We had furlough schemes here and across the world where basically the governments were saying, right, or companies were saying, we can't afford to pay you. The governments were paying a percentage of their wages, but they were told they couldn't work. So with furlough schemes, what you find is people are taken away from part of their personal identity as a working person, as a provider within the family, irrespective of gender and gender identity. And that can lead to frustrations being built up as well. You've got the element that clicks back with the isolation. You're no longer seeing your work colleagues, you've not got the break from the family members and so on. And also you're lacking identity as a person who works. So that element is clicking in as well. Within this as well, we've also got the next step on, which was the sudden unemployment many people faced when their jobs were no longer able to be viable. And so they lost their employment, lost their identity, and then unfortunately lost their financial ability to cope. And so financial concerns, unemployment issues, and so on build up the stresses and creates the right melting pot for lashing out if you're a violent person or have a predisposition to that type of violence of whatever type. And also for the survivor or the victim of violence, there's the reduced ability to get help because of these movement control orders, because of the lockdowns. You might be able to get an element of help through going to seeing a therapist online, but if you are trapped with your violent partner, that might be a challenge for that person. So they weren't able to get out of the house. They weren't able to necessarily go to refuges and so on. So they were, in essence, trapped inside with their abuser. And of course, a basic social element that, can fit in with isolation. When somebody's isolated and then they meet people, they can be aggressive. You see this in animals as this is a very primitive, let's sort out our hierarchy within our social setting. But also it's a very well-known fact, group people together in small confined spaces, frustrations occur, and they then tend to lash out in violence. And we see this perhaps in homes where there is a large family in a small environment, a small flat or a small house, certainly where there may not be an access to outside within it. So that can push up that level of aggression that people are experiencing. And we mustn't forget coercive control. COVID and the pandemic became a perfect environment, so to speak, for coercive abusers, people who are using emotional abuse in order to control. We've got to remember emotional abusers, and all abusers to a certain extent, will use the violence to be able to control somebody's actions. For the emotional abuser, the coercive control abuse, and coercive basically means it's not very overt things that are going on. It's very covert, it's almost in the background. And part of the power of a coercive abuser is the fact that they do it in a way that the survivor or the victim questions what's happening to them. Are they actually seeing it as happening, or is it in their imagination, something that the abuser will certainly promote? But you've got to remember, part of the abuser's role within this is to cut off everybody. So we get containment. You get the fear that's engendered by the abuser, which then controls the person who's the victim. And they use the threat of contagion to keep those people far, far away from their support systems, family, friends, etc. So identifying the people who may be at risk, and quickly go through this for you. Now, the things I want you to just bear in mind as I look here, these are pointers only. They're part of a picture that we need to look at in an objective perspective. So they are part of that picture. They are not there for you to make assumptions about the existence of trauma. So a person's presenting, they may not have said anything to you, but some of these pointers are coming up. They might be indicators that trauma is present, but they might not. We need to remember that these indicators may have many different explanations as to their origin. This is giving us a picture, an overall view of the client for our understanding. And a reminder, only work with trauma with client insight and consent. So elements that we might be seeing, becoming reticent to talk about their partner for whatever reason. If you're questioning them a bit about their partner and they don't want to talk about it, there may be a good reason why, but there may also be the reason that they are under coercive, or they are under some form of abusive relationship. Talking about their partner, they may present as being fearful or nervous. You might find them avoiding social and other engagements during lockdown. You might find that presents with avoiding Zoom meetings and Zoom groups, etc. He might reply, or they might start reporting a lack of financial control in their relationships. You might hear them be feeling guilty because of what they're doing in the home. They get unnecessary guilt laid upon them by an abuser. And you might find within that they feel pressurized to take recreational drugs as well. The partner is pressurizing them. And going from the recreational, you might also find they feel pressurized to take or not take medications, health controlled by the abuser. And you may also find that part of their coping strategy is to lie about taking medication. For example, the abuser may want the partner to become pregnant, and so the woman is lying about taking her taking any medication, says she's not taking contraception when she actually is. And it's part of trying to break that coercion. Feeling pressurized to have sex or to perform distasteful sexual acts, those that they find distasteful themselves. And reports that their partner belittles them in front of others. These you might be picking up on. Again, as I say, these are just indicators, they're hints. They may be told that they forget or misremember things. It's called gaslighting. They might have a proper memory of something, but a coercive control abuser will gaslight them by saying, no, you don't remember that right. That's not the right thing. That's not what you're going to be. That's not what happened back then. And apart from the guilt that they feel about their own behavior that's put on them by the abuser, they'll take responsibility or blame for any bad behavior by the partner themselves. They may appear detached, slightly vacant, not quite with it when they present. This is a dissociation experience that they might have. So they might appear dissociated to you. There are many reasons why somebody may be dissociated, but one of them is it's a survival mechanism for abuse. Likewise, they may lack affect. They show no emotion. They're split off from that. And at the same time, you might find some of them are highly emotional. They are associating into their emotions far too readily. Because of the nerves that they're experiencing, because the stress response is on all the time, high levels of adrenaline and cortisol, you might also find that they fidget excessively. They're moving around for more than a person perhaps who's meeting you for the first time. And because of the dissociation, their cognitive processes become very easily distracted. They're 1, 2, 3, jump from different thoughts all the time. And it's quite difficult to follow those, their thought patterns. And with trauma, you might start to experience, or you might be the recipient of transference, where they're seemingly getting very angry with you for no reason that you know of, but this is a transference experience. They're angry at their abuser, can't be angry at that person, so they transfer the anger onto you or other emotions that might be present. And some of my own observations working with people who have later disclosed abuse have been things like accessing very deep trance states as a result of the dissociation that they're experiencing. Because they dissociate very easily, they stay dissociated, they stay in a trance-like state. You might find defense mechanisms that inhibit access to the trance, because those people, some people will go very deeply because of the dissociation, but defense mechanisms will shut down their ability to go into trance because it becomes an unconscious threat to the material they're trying to push away. You might also find they'll go into trance, but the moment you try looking at anything in the past, whether it's looking at emotional upset or trying to find positive resources, the defense mechanisms again block that person. And you might pick up on recently acquired maladaptive behaviors, binging, for example, increased alcohol consumption as a method of coping with their experience, and so on. But again, all of these may have their own particular reasons for doing that are not related to this. And quite quickly, should you address your concerns with your client? Well, first and foremost, if there are minors involved, just prioritize any safeguarding concerns at all that you may have. The minor's safety is always going to be paramount in this. If there is a safeguarding issue, then you need to follow the recommendations and the law as it stands with regard to your area of the world. If you are going to gently inquire, we don't overtly inquire, you just use meta-model questions, very gentle meta-modeling, peeling away the layers of meaning, what they're talking about. And also very open-ended in your questioning. You don't ever want to use leading questions. You don't want to create an issue accidentally where an issue does not exist. And likewise, don't interrogate somebody if they're not comfortable with a line of questioning. Just avoid going down that route, because if you do interrogate, this perpetuates the abuse. And never ask if they are being abused. That's a big no-no. If they haven't disclosed anything and you ask them, you'll probably find A, you'll break rapport, B, bang, the defense mechanisms will shut you out. And likewise, never label that person as, oh, I think you've been abused. Don't ever label them, because again, you risk insulting them, you risk locking them out because they're not ready to acknowledge it, and you might actually be wrong. So just bear that one in mind. So if you do have concerns about an abuse scenario, well, should you refer or not? Well, only work with trauma if you're qualified to do so, first and foremost. I'll always say that. But only refer on, I would recommend, if your client wants to work on acknowledged trauma and you don't have the skill set to do so. Again, goes to that area here. If the client doesn't want to, if the client's not acknowledged or disclosed, then the thing to remember here is, if it's present, it can take time to be acknowledged by the client. And whether you are able to treat trauma or not, the rapport that you have with your client can help this process of uncovering. If it comes up and you're not able to treat, then refer that client on. And remember, where there is only suspicion, there may not be trauma. And as always, the coda here is, if in doubt, no matter how well qualified or experienced you are, seek clinical supervision. So the global mental health provision for abuse survivors, we know, is seriously overstretched, and there have been several recommendations that have been coming out. One, there's been a big call for more technology-based solutions to help alleviate this pressure for the abuse survivors and alleviate the pressure on the healthcare systems. Research has shown, quite interestingly, that people are more likely to share via technology-based solutions. And also research is indicating that there may be better therapeutic outcomes with the technology-based interventions. This is very interesting. It's very early days, but that's something we do need to keep an eye on, because we're all forced into doing online therapy because of lockdowns, and it seems to be very effective. And a very big thing for the pandemic, COVID technology-based solutions don't risk COVID contagion. So very quickly to conclude, as I know I'm just about at time now, domestic abuse is on the rise because of COVID restrictions. We know that. COVID-related domestic abuse is still very much hidden, and I reckon we'll be seeing those statistics rise. And the technology-based solutions provide a very safe and effective conduit for therapy, and the efficacy of that is being increased all the time. And then therapists of all disciplines can effectively help alleviate this whole shadow pandemic of the abuse and whatever else is likely to come out of this. So thank you all very much, and I shall start to hand back.
Thank you, Peter. I think, yeah, we have a question, but I think you have also addressed it, because I think Dr. Soraya was asking about gaslighting, but then you did bring that up as being part of the mechanism and the abuse itself. I'm just looking out to see whether we have any other questions. And as usual, Peter has a fantastic presentation, and I think we learned quite, yeah, and it's very interesting. So let's see. Okay, I think, all right, we'll take one question from Joanna. How do you work with abuse clients online? Using your online?
Oh, very, very easy. Very, very easily. I spend time with them, ensuring that they're in a room where they can feel that they are safe, they're not going to be overheard, and so on. Nowadays, with the lockdowns becoming very loose now, clients are able to do that. I find, and this is my feedback I've had from clients, abuse survivors and trauma survivors of all types, is that they feel a comfort about being in the home, even if it's the home in which they're being abused. They're in a familiar environment, they've got familiar cues around them. So there is a comfort there that is being used to help them open up. You know, anyone who knew me pre-COVID, pre-pandemic, knew I was quite anti-online therapy. Bit of a closed mind, but then I started looking at it and looking at the research, and certainly this whole lockdown the research has been piling in and has shown the efficacy of online therapy. I love it now. At the moment, I choose not to see people face to face. We're not locked down here, but we still have a risk of COVID here. Now, what I like to do is seeing them online. We have that ability to I still make the rapport. I work with them in exactly the same way as I would always work with the client face to face. Things like idiomotor responses and all of that, you can't see them in the fingers, but having a talk to people like Ruben Bettino and others preeminent in the field, they're all now saying, we might have all been taught, well, you don't use head shakes and head nods because of the risk of conscious interference. They're all now saying that the use of installing IMRs in the head is quite a valid way of working with that. And, you know, depends on the resolution of cameras, whether, you know, if you did see the fingers, but I find clients seem to be more willing to engage as well online, because they don't have that trip to the therapy room, having to take either time out of work or get home late because they've been for therapy. There is a huge amount, I think, of positivity with regards to doing things online. People are feeling safer, and as long as you're using some, you know, a therapy center or something like Zoom, where you've got that security, the HIPAA compliant security, you'll be fine. And don't record unless your client specifically asks you to do that. And also, just tapping into a bit of what Linda was saying with regard to children, I also now do a lot of my own audios that I use as part of the therapy process. So I might record something specific. I have some generalized things. So that also is something that I use as part and parcel of what I give my clients now.
Okay, Peter, we're going to channel you the rest of the questions as the time is up. Thank you once again. It's superb to have you online with us. Thank you so much.
Thank you.
Back to you.
Bye-bye.